Slides are moving.
Yes, yes, they are.
मुझे लग रहा है वो टेक्निकल चीज, मतलब आई थिंक, मतलब एआई के जमाने में हम लोगों को रिपीट भी करना पड़ेगा सर काफी ज्यादा मुझे लग रहा है. Okay, so this is where I was. I think all of us have seen sort of pancytopenia patients multiple number of times, during the clinical practice. And yeah, so if we try to understand कि how do we approach a patient of pancytopenia? So in clinical practice अगर हम लोग बात करते हैं सर कि pancytopenia अगर लेकर के कोई सीबीसी का पेशेंट का रिपोर्ट लेकर आया है, हीमोग्लोबिन 6 है, प्लेटलेट 10,000 है, डब्ल्यूबीसी काउंट 2,000 है, 2,500 है, तो द फर्स्ट थिंग दैट एटलीस्ट वी ट्राई टू सॉर्ट ऑफ लुक एट इट इज कि हिस्ट्री क्या है. दैट इज द मोस्ट इंपॉर्टेंट एस्पेक्ट कि बैकग्राउंड क्या है, कि पेशेंट ने कोई ऐसी मेडिसिन ली है, फीवर की कोई हिस्ट्री है, और मतलब व्हाट आर द ड्यूरेशन ऑफ द हिस्ट्री, सिम्टम्स क्या है, ब्लड ट्रांसफ्यूजन की कोई हिस्ट्री है. सो दिस इज ऑल अ वेरी इंपॉर्टेंट एस्पेक्ट दैट कैन हेल्प अस ड्राइव इन अ प्रॉपर डायरेक्शन कि भी चल क्या रहा है, पैनसाइटोपिनिया अगर किसी को है तो क्यों है. दैट इज फॉलोड बाई मेटिकुलस फिजिकल एग्जामिनेशन, ऑर्गेनोमेगली है कि नहीं है, कोई लिम्फ नोड्स एनलार्जमेंट है कि नहीं है, कोई स्टर्नल टेंडरनेस है कि नहीं है, बोन पेन्स है कि नहीं है, तो इस तरह कोई स्किन डिस्कलरेशन है कि नहीं है. सो ऑल दीज पैरामीटर्स आर द सेकंड मोस्ट इंपॉर्टेंट कंपोनेंट कि जी जिसके बेसिस पर वी कैन से कि हाँ भी दिस आर द पॉसिबिलिटीज. We can start making the differential diagnosis for a patient with pancytopenia, and of course followed by a complete blood count with peripheral smear, and of course a reticulocyte count. So based on these parameters, ultimately what we zero in is these three things. अगर मैं समझाने मतलब इफ यू ट्राई टू अंडरस्टैंड दैट द फैक्ट्री वेयर द ब्लड इज प्रोड्यूस इज अल्टीमेटली बोन मैरो, तो अगर किसी भी व्यक्ति को पैनसाइटोपिनिया है, दैट इज हीमोग्लोबिन, डब्ल्यूबीसी एंड प्लेटलेट्स ऑल थ्री आर लो, देयर इज प्रैक्टिकली ओनली थ्री पॉसिबिलिटीज इन दिस वर्ल्ड. वन पॉसिबिलिटी, जी यहाँ पर फैक्ट्री जो है, फैक्ट्री बंद पड़ गई है, फैक्ट्री काम नहीं कर रही है फॉर एनी रीजन, द बोन मैरो इज नॉट एबल टू सफिशिएंटली प्रोड्यूस द कंपोनेंट्स ऑफ द ब्लड. दैट इज वन पॉसिबिलिटी. सेकंड पॉसिबिलिटी, जी बोन मैरो ठीक काम कर रही है, बट वेन एवर द ब्लड इज कमिंग इन टू द पेरिफेरल सिस्टम, इट इज गेटिंग डिस्ट्रॉयड फॉर वॉट एवर रीजन. So it can be either a problem of the bone marrow, that is production problem, or it can be a problem in the peripheral blood, that is it is getting destroyed somehow. And third possibility can be a combination of three, of all the two, that is bone marrow भी नहीं बना रहा है और साथ में peripheral में टूटता भी जा रहा है. So these are the three clinical contexts that can arise etiologically at least, जो कि एक्सप्लेन कर सकते हैं किसी का पैनसाइटोपिनिया. नाउ इफ वी ट्राई टू अंडरस्टैंड इन मोर डेप्थ कि जी बोन मैरो क्यों नहीं बना पा रहा है, सो आइदर द बोन मैरो कैन बी कंप्लीटली शट डाउन, बंद ही पड़ गया है, एप्लास्टिक अनीमिया हो गया जी, बोन मैरो के अंदर कोई सेल्स ही नहीं है जो वो बना सके. दूसरी पॉसिबिलिटी कि जी बोन मैरो के अंदर सेल्स तो हैं पर वो ठीक से काम नहीं कर पा रहे हैं, दैट इज माइलोडिस्प्लास्टिक सिंड्रोम, अ डिजीज मोर कॉमनली सीन इन द एल्डरली. थर्ड पॉसिबिलिटी कि जी बोन मैरो के अंदर कुछ सामान जाकर के बैठ गया है, कोई फॉरेन सब्जेक्ट जाके बैठ गए हैं, and because of that the bone marrow is not able to work properly, produce the normal blood components properly, and that infiltration can essentially be because of anything, whether it is a malignancy, whether it is an autoimmune disorder, whether it is because of some infection or a granulomatous disease like tuberculosis. लास्ट बट नॉट द लीस्ट कि जी बोन मैरो काम ठीक से कर रहा है बट उसके पास खाना बनाने का सामान नहीं है, दैट मीन्स न्यूट्रिशनल डेफिशिएंसी, कि भाई बॉडी के अंदर B12 की कमी हो गई है, फोलेट हो गया, बोन मैरो बनाना तो चाह रहा है पर बोन मैरो बना नहीं पा रहा है बिकॉज दे डोंट हैव, द बोन मैरो डज नॉट हैव प्रॉपर इंग्रेडिएंट्स दैट आर रिक्वायर्ड फॉर द प्रोडक्शन ऑफ द ब्लड कंपोनेंट्स. सो दीज आर द कॉमन कॉजेज जिसकी वजह से ब्लड से रिलेटेड, ब्लड प्रोडक्शन से रिलेटेड यानी कि बोन मैरो से रिलेटेड प्रॉब्लम्स हो सकती हैं इन टर्म्स ऑफ डिफेक्टिव bone marrow production. The second is peripheral destruction. That means कि blood बन गया bone marrow के अंदर, blood मतलब peripheral blood में आ गया पर वहां पर टूट गया because of autoimmune, whether it is ADCC or it is CDCC, complement mediated destruction, or antibody dependent destruction. Either of them can lead to destruction of the hemoglobin, WBC platelets, that is immune mechanism of destruction. The second is spleen enlargement, maybe hyperfunctional spleen or splenic enlargement, splenomegaly की वजह से splenic sequestration हो रहा है, that is destruction of the blood in the periphery because of the enlargement or hyperfunctional spleen, that is splenic sequestration, that is another possibility. कुछ रीजंस ऐसे होते हैं जिसके अंदर बोन मैरो के अंदर भी दिक्कत हो सकती है, ब्लड के अंदर भी डिस्ट्रक्शन चल रहा है साइमल्टेनियसली, एंड द मोस्ट इंपॉर्टेंट प्रोटोटाइप ऑफ दिस इज PNH, that is paroxysmal nocturnal hemoglobinuria, जिसके अंदर अननेसेसरी कॉम्प्लीमेंट एक्टिवेशन की वजह से, so body's own plasma membrane do not have that substance to inactivate the complements. Because of this, the plasma membrane of all the blood products is hypersensitive to destruction by the complements, and this includes both in peripheral blood and in the bone marrow. That is what is called as PNH or paroxysmal nocturnal hemoglobinuria. Another prototype of the destruction at both the places is HLH. HLH का मतलब है कि hyper activation of the immune system leading to a release of lot of cytokines. That cytokines ultimately lead to destruction of the blood both in the periphery and in the bone marrow. That is what is called as HLH, hemophagocytic lymphohistiocytosis. And yes, that's a critical condition that we will be discussing subsequently. So yes, one by one, very shortly, I'll be discussing कि भाई ये जो independently हमने सारे के सारे parameters या causes discuss करे for the defect at different places that can contribute to the generation of pancytopenia, that I'll be discussing in next 5 to 7 minutes. फर्स्ट कॉज हमने बोला एप्लास्टिक एनीमिया, जी बोन मैरो बंद पड़ गया, काम ही नहीं कर रहा. Acquired aplastic anemia, what is also called as idiopathic aplastic anemia, is one of the most common causes of aplastic anemia. Interesting thing here is there can be different causes कि भी बोन मैरो क्यों नहीं काम कर रहा है. One is genetically बोन मैरो काम करना बंद कर दिया है. That's a problem of the bone marrow itself. That is called as idiopathic aplastic anemia. The other two possibilities that are relatively more common is drug induced, and second is infection induced, and there is another cause called radiation induced. So these are the common causes जिसकी वजह से bone marrow का suppression हो सकता है. So if you talk about idiopathic aplastic anemia, bone marrow is stopped to function because of the defect in the bone marrow itself. The primary problem is in the bone marrow. How do we diagnose it? By a bone marrow aspiration and a bone marrow biopsy that essentially shows that the bone marrow is empty. How do we treat it? It is essentially dependent on the age of the patient, how to treat that patient. But if it is a younger patient, preferable treatment is bone marrow transplant, and a younger patient, bone marrow transplant, and an older patient can be treated with the immunosuppressive treatment. The most common cause of aplastic anemia, however, is drugs. मेरे ख्याल से हम में से कोई भी ऐसा नहीं होगा जिन्होंने एंटी एपिलेप्टिक्स हो गए, एंटी साइकेट्रिक मेडिकेशंस हो गए, sort of एंटी वायरल मेडिकेशंस हो गए, जिनकी वजह से पैनसाइटोपिनिया नहीं देखा होगा. वी ऑल हैव सीन कि भाई क्विटियापिन खा रहे थे, पैनसाइटोपिनिया हो गया, लेवेट्रासिटाम खा रहे थे, पैनसाइटोपिनिया हो गया. सो दीज आर वेरी कॉमन सॉर्ट ऑफ क्लिनिकल कॉन्टेक्स्ट इन विच वी सी पैनसाइटोपिनिया. जरा सी एक हिस्ट्री पूछनी है कि जी भी कोई लंबे समय से मेडिसिन चल रही थी क्या, दैट गिव्स द आंसर कि भी हाँ भाई इसकी वजह से पैनसाइटोपिनिया हो सकता है, हो रहा हो. SSRI is very commonly known to cause pancytopenias. Certain antibiotics, although rarely, like meropenem, can contribute to sort of this thing, and tigecycline we know is known to cause thrombocytopenia, but rarely pancytopenia. So these are very interesting and important causes of drugs as the cause for pancytopenia that should never be missed. पहला क्वेश्चन pancytopenia में अगर है तो कोई दवाई तो नहीं खा रहे. रेडिएशन इज अ क्वेश्चन दैट इज ऑलवेज हॉटली डिबेटेड कि जी कितने एक्सरेज कराना सेफ है कि जी हमें कोई दिक्कतें ना हो जाए, सेकंड कैंसर नहीं हो जाए, हमको पैनसाइटोपिनिया ना हो जाए. इसके लिए हाउ मच रेडिएशन is safe, is considered safe. So they say overall lifetime exposure of more than 5 gray has got a 10% incidence of developing aplastic anemia. अब सवाल ये है कि जी 5 ग्रे का क्या मतलब होता है. एक सीटी स्कैन से करीबन 10 से 15 मिलीसीवर्ट का रेडिएशन एक्सपोजर मिलता है. दैट इज ऑलमोस्ट इक्विवेलेंट टू मोर देन 150 सीटी स्कैन्स इन अ लाइफ टाइम. तो 150 से ज्यादा अगर कोई सीटी स्कैन कराता है, देन देयर इज अ 10% चांस दैट पर्सन मे डेवलप अ पैनसाइटोपिनिया that may be related to a repeated exposure to radiation. इन्फेक्शंस, आई थिंक हम में से कोई ऐसा नहीं होगा जिन्होंने इन्फेक्शन इंड्यूस्ड पैनसाइटोपिनिया, स्पेशली वायरल इन्फेक्शन इंड्यूस्ड पैनसाइटोपिनिया नहीं देखा होगा. वेरी कॉमनली flu is known and notorious to cause variable pancytopenias in different patients. We all have seen EBV, very notorious. Hepatitis, different type of hepatitic viruses known to cause pancytopenia, not only related to when they develop into CLD and hypersplenism, but per se the viral infections can also lead to the pancytopenia. HIV is very sort of notorious to cause a pancytopenia, and recently we had seen in the COVID era, and now also we are seeing, although not very prominent pancytopenia, but yes, less than optimal as per the definition. The pancytopenia is also showing up in COVID context. Most of the times, the viral pancytopenia recovers on its own as the viral clearing happens. But yes, important note is to be made about hepatitis A virus that can sometimes cause prolonged and life-threatening pancytopenia. And there have been instances where hepatitis A-induced pancytopenia, aplastic anemia could only be rescued by a bone marrow transplant. So yes, even viral drug-induced sort of infection-induced pancytopenias that are not recovering beyond 2 to 3 weeks should be sort of considered for a further line of treatment if they're not recovering by conservative treatments. Congenital aplastic anemia, stem cells are defective in patients younger than 40 years. That is called as congenital aplastic anemia. The most common prototype of congenital aplastic anemia is Fanconi anemia, and there are more commoner, sort of relatively less commoner and rarer subgroup of congenital aplastic anemia. Interesting and important point here to note is कि कई बार ये वाले जो mutations होते हैं इन congenital aplastic anemia के patients के अंदर, they are cryptic. And that means they can manifest in adulthood also. So we have many times seen common variable immunodeficiency and things like that, aplastic anemia presenting at 40 years, 45 years of age, and they somehow turn out to be mutation positive for either Schwarzman diamond or dyskeratosis mutations. So in that case, it is important to diagnose them because the treatment is different for proper congenital aplastic anemia irrespective of age. बोन मैरो इन्फिल्ट्रेटिव डिसऑर्डर्स, यस, मोस्ट इंपॉर्टेंट माइलोफाइब्रोसिस। जी बोन मैरो के अंदर फाइब्रोसिस हो गया है, वेरी इजीली कैन बी पिक्ड अप। पैनसाइटोपेनिया है, पेरिफेरल ब्लड आप पेरिफेरल स्मीयर आप कराएंगे, उसके अंदर आपको सॉर्ट ऑफ टीयर ड्रॉप सेल्स दिखाई देंगे, एंड जब उसका बोन मैरो करेंगे, बोन मैरो के अंदर एस्पिरेट कुछ नहीं आएगा, ड्राई टाइप विल बी देयर, और जब उसकी बायोप्सी देखी जाएगी, बायोप्सी के अंदर देयर विल बी इंटेंस एरियाज ऑफ फाइब्रोसिस दैट कैन बी ब्रिलियंटली लाइटेड अप ऑन अ रेटिकुलन स्टेन इन अ बोन मैरो बायोप्सी सैंपल. How do we treat it? The treatment is by either conservative treatment if it is an early stage of myelofibrosis. If it is a spent phase of myelofibrosis, in that case, it has to be treated with a bone marrow transplant with a suitably matched donor. Other things that can infiltrate into the bone marrow, whether it is different types of blood cancers, we have seen n number of times, lymphomas infiltrating into the bone marrow, leading to pancytopenia. And the presentation is not lymph node enlargement or spleen enlargement. The presentation is pancytopenia in Hodgkin lymphoma patients, that is like infiltrating into the bone marrow, and they are presenting as a sort of pancytopenia patient, and ultimately on workup we find that there is a lymphoma sitting there. And more commonly, yes, solid tumors infiltrating into the bone marrow. मतलब वहां पर जब पैनसाइटोपिनिया के लिए बोन मैरो किया गया, बोन मैरो के अंदर ट्यूमर्स बैठे हुए थे, उन ट्यूमर्स के लिए जब उन्होंने वर्कअप किया तब पता चला कि जी सॉलिड ट्यूमर ऑफ ओवरी था जो कि बोन मैरो में मेटास्टेटिक था और उसकी वजह से पैनसाइटोपिनिया हो रखा था. In pediatric population, neuroblastoma is very important cause of presentation as pancytopenia. It infiltrates into the bone marrow, sits there, causes pancytopenia, and that can at times be picked up by relevant investigation. How do we treat these type of infiltrative disorders? Depends on what is the nature of infiltration. If it is a blood disorder like acute leukemia, it has to be treated by chemotherapy relevant to that, followed with or without a bone marrow transplant. If it is a sort of a solid tumor malignancy, it has to be treated with that. If it is a myelofibrosis, it has to be treated like that. If it is infection-induced granulomatous infiltration, I'll come to that, I think. That is here, yeah, granulomatous disease infiltration like tuberculosis or sarcoid, it has to be treated accordingly. Autoimmune myelofibrosis is not a very uncommon entity. It is relatively seen. But the only important thing is we have to keep a high index of suspicion. जी हमने पैनसाइटोपिनिया है, ऑर्गेनोमेगली है, बोन मैरो करा के देखा, बोन मैरो के अंदर माइलोफाइब्रोसिस आ गया, और माइलोफाइब्रोसिस के लिए हमने जब जेनेटिक टेस्ट करा के देख लिए, जेनेटिक टेस्ट वाला और नेगेटिव, सो देन यू थिंक गो बैक एंड थिंक कि भाई और क्या रीजन हो सकता है इस पेशेंट के अंदर माइलोफाइब्रोसिस का, व्हाट आर द सेकेंडरी पॉसिबिलिटीज ऑफ माइलोफाइब्रोसिस इन दिस पेशेंट. द फर्स्ट डिफरेंशियल फॉर दैट इज autoimmune myelofibrosis. You get a ANA done and other further workup for autoimmune workup done, it turns out to be positive and you are diagnosed it as a autoimmune myelofibrosis. Very simply, it can be treated with simpler immunosuppressants. So yes, these are the commoner causes for sort of infiltrative disorders. Nutritional deficiencies, B12. मतलब it is interesting and important to note, भाई पैनसाइटोपिनिया with a high MCV, मतलब 120 प्लस अगर MCV है, LDH उनका 2000 है, छोटी सी स्प्लीन पैल्पेबल है, indirect bilirubin बढ़ा हुआ है, SGOT, SGPT normal है. This is a classical picture in which a patient with megaloblastic anemia presents. So megaloblastic anemia on this earth is one of the most common causes of pancytopenia as a presentation. Yes, copper deficiency can also sometimes present. Elderly age group के अंदर 60 years plus के अंदर if the patient comes with a pancytopenia, the first differential that comes, of course, one is megaloblastic anemia. आप simply history patient पूछोगे, vegan history है कि non-vegetarian है, but again that is not a very important history क्योंकि non-vegetarians के अंदर even sort of we now are seeing a lot of megaloblastic anemias. But yes, having said that, so अगर high MCV है 120 plus है, only two differentials are possible in this world. One is megaloblastic anemia, other is a hemolytic anemia. So only two differentials that are possible. Myelodysplastic syndrome usually have a high MCV in the sense of 100 plus MCV रहेगा, and when you do a bone marrow, it will show first the peripheral smear will not show any malignant cells, it will show dysplastic neutrophils. When you do a bone marrow, elderly patients के अंदर especially that will show dysplastic changes in one or more lineages of the blood components, whether it's erythroid, myeloid, or megakaryocytic, may show dysplasia, and that can be further confirmed by genetic testing. Here I want to just stop, pause and highlight कि आज की तारीख में कम से कम hematological malignancies के अंदर sort of this genetic markers are now playing a very important role, not only in terms of prognostication but also in terms of deciding the treatment. जी फॉर एग्जाम्पल अगर किसी को SF3B1 आ गया तो उस केस में देयर इज अ डिफरेंट ट्रीटमेंट अवेलेबल फॉर दैट पर्टिकुलर पेशेंट विद माइलोडिस्प्लास्टिक सिंड्रोम एज कंपेयर टू हु हैज गॉट DNMT3A. So आज की तारीख में the treatment is more of molecular driven, and by default, at least at our center, we are trying to do sort of molecular testing for relevant patients in 100% of those who require, and where the treatment indications are guided by the molecular diagnostic workup. Similarly, MDS, if it is a low risk MDS, the chances of progression to leukemias are less. In those cases, they are treated more of conservatively by supportive treatment. But yes, if they are more prone to develop blood cancers, they are treated optimally by a bone marrow transplant. Coming to the second most common component of the pancytopenia, that is peripheral destruction. Yes, autoimmune SLE is the prototype of that, and that can lead to pancytopenia. Splenic sequestration, so splenic enlargement or hypersplenism because of either CLD. I think मतलब मेरे ख्याल से हमारे पास गैस्ट्रो की तरफ से जितने भी रेफरल आते हैं, most of the times it is for CLD induced pancytopenia, most commonly. Yes, there are other reasons also, but one of the most common reasons why we get referrals from gastro departments are for CLD induced pancytopenia. Yes, rarely we have seen cardiology references for pancytopenia because of cardiac failures, congestive failure. Hemoglobinopathies, thalassemia, sickle cell anemia, because of splenic enlargement, can present with pancytopenia very commonly. PNH and HLH, they are the prototypes of the destruction that is happening at both the places, that is the bone marrow and the peripheral blood. PNH, as I discussed in the beginning, that it is because of the increased sort of susceptibility of the plasma membranes of the hematopoietic cells to destruction by the complements. So in that case, how to diagnose it? It is diagnosed by a simple blood test called FLAIR for PNH. It is a flow cytometry based, in which they try to find out whether that sort of substances that are required on the surface of the hematopoietic cells that will inactivate the complement are present or not. So that is a test called FLAIR. It's a flow cytometry aerolysin based test that can just tell us, okay, that molecule is there or not. If it is not there, that means it is a PNH. And the classical way to treat is since the complements is the problem, we can treat it by sort of complement inhibition by a molecule called eculizumab. That is supposedly Times magazine के अंदर एक बार इसका cover page पे छपा था. Eculizumab was at one point of time was considered as most costliest medicine in this world. At that time, it was available when it was launched by the company. So at that Alexion or something. So at that point of time, it was available at some 4 CR per month of cost, something like that. Yes, for those patients जिनको ये treatment available नहीं हो सकता, for them the bone marrow transplant is indicated for this category of patients. HLH क्या चीज है? HLH I was discussing, it is hyperactivation leading to cytokine release, and that is leading to the destruction of the hematopoietic stem cells. This cannot be neglected. HLH as a diagnosis for any of us, I think, cannot be neglected. Any patient who is sick with fever, with pancytopenia, with variable organomegaly, the first click that should come to us is for HLH. It cannot be neglected because it is associated with a very high risk of mortality, and maybe steroids at times can be life saving. And भाई हम लोग fever सोच करके pancytopenia सोच करके most of the times we hesitate in adding steroids. But this is a condition जिसके अंदर अगर आपने steroid नहीं डाला, patient will surely die. So I'll come to the second component of this, that is interesting case. But before going to the interesting case, मैं थोड़ा सा एक बार वापस sort of interest जगाने की कोशिश करूंगा and just try to see कि एक छोटा सा fun quiz, भाई जिसको भी पता हो, I'll just stop for 5 seconds for a similar type of quiz that we did in the beginning. कौन सी movie है? I'll just wait for 5 seconds maybe. Can anyone guess the name of the movie? Okay, so movie name is Thappad. So just on a lighter note, just to keep the things light and comfortable for all us, because लगता है कि all of us are waiting for the dinner. But yes, I'll just finish off in next 15-20 minutes. So some interesting cases. So just 6 interesting cases I have, and then I'll end with a small fun quiz in the end. So this is the first case. 61-year-old male who presented to ER with a back pain for 5 days, and his MRI had shown some burst fracture but no nerve root compression. On evaluation, his CBC was showing a pancytopenia with a preserved neutrophil lymphocyte ratio. Creatinine was high, that is 6.5. Total proteins was raised with an albumin globulin ratio reversal. The liver enzymes were relatively normal, and there was hypercalcemia and hyperphosphatemia. Pancytopenia, high creatinine, high calcium, high phosphate, high protein with EG reversal. This is the picture, and the patient is presenting with fracture. Any guesses? I think मेरे को लगता है कि इसमें बहुत ज्यादा डिफरेंशियल डायग्नोसिस बनते नहीं है. वन इज डेफिनेटली माइलोमा एंड द सेकंड इज सीकेडी, जो अभी आज तक कभी पकड़ में नहीं आया और इस बार प्रेजेंट कर गया विद अ फ्रैक्चर एंड हाइपरकैल्सीमिया एंड थिंग्स लाइक दैट. दीस वर द पॉसिबिलिटीज. सो ही वाज वर्कड अप एनीवेज. तो इको के अंदर सॉर्ट ऑफ अल्ट्रासाउंड के अंदर द किडनी साइज वाज नॉर्मल, सो अनलाइकली टू बी सीकेडी. अच्छा, एमबैंड करा के देखा. सो दिस इज अ रीसेंट केस दैट वी हैड. सो एमबैंड करा के देखा, एमबैंड वाज नेगेटिव. सो स्टिल कैन इट बी प्लाज्मा सेल डिस्क्रेजिया. हमने पेट स्कैन कराया, हमने बाकी सब कुछ कराया इसके बाद में जाकर के, बट can this be still a plasma cell dyscrasia? The question is that if the M-band is negative, can it still be a plasma cell myeloma? The answer to that is yes. It is most likely a light chain myeloma. जो हमने उसका FLC ratio करा के देखा. So it was a kappa light chain myeloma, and that was proven further in the bone marrow evaluation and the other tests that were done. This patient was treated with the proper treatment. She is undergoing the chemotherapy at present, and sooner or later she will proceed to a bone marrow transplant. So that is about a myeloma. This is the second case. This is rather an interesting case that had us fixed for a lot of time. So 38-year-old policeman from Karol Bagh area, he developed. So this was not a happy ending for us. This was a bad ending for us. A learning experience for us, I would say. So he developed fatigue, like on evaluation was found to have anemia. He was worked up initially in 2 different hospitals, including Tata Mumbai. They had diagnosed it as acute myeloid leukemia, but at that time they did not believe it. So there was some common connect between us and this patient in Rewari. So they came to us, and ultimately we further worked up and confirmed that it is acute myeloid leukemia. So if Tata is confirmed, one another big hospital in that area is confirmed. So there was no doubt. So it was acute myeloid leukemia, and these were the mutations that he had. So he was started on the chemotherapy protocol, a standard chemotherapy protocol, not very standard, but yeah, so that's an upcoming chemotherapy protocol. So the protocol for us is we give 1 to 2 cycles of chemotherapy before proceeding to a transplant, bone marrow transplant for a eligible patient. So this patient received 1 cycle of chemotherapy. At that time, he was more or less in remission. He received the second cycle of chemotherapy, after which he was planned to undergo a bone marrow transplant. But the problem started after this. After receiving the second cycle of chemotherapy, he never came out. What happened? So this is what happened. So usually हम लोग जब chemotherapy देते हैं तो अभी expect कि भी 2 से 3 हफ्ते के अंदर the bone marrow will recover, the normal hemoglobin WBC platelets will recover, and after that the patient can be wait for 1 week 2 week, and after that can proceed to bone marrow transplant. इस केस में क्या हुआ कि जी 22 दिन तक तो bone marrow recover नहीं किया. We kept waiting. उस टाइम तक कोई fever नहीं था. Then he started developing fever. Persistent fever spikes by at the end of 1 month when we started the chemotherapy. नो क्लू भाई. जब हमको और कुछ समझ में नहीं आता ना, जब फीवर चल रहा है, पेशेंट सिक हो रहा है, तो हम लोग वी ऑलवेज थिंक ऑफ HLH एज द फर्स्ट पॉसिबिलिटी. वी सेंड द वर्कअप फॉर HLH. फेरिटिन हाई, वेरी हाई. So ferritin of more than 10,000 should more or less be considered as sine for a HLH. So high ferritin, high triglycerides, low fibrinogen is a biochemical hallmark for HLH. We did the bone marrow. Bone marrow showed presence of some occasional hemophagocytic cells. We started the patient on IVIG and steroids. That is the recommended treatment for HLH. We were happy. Okay, the moment we started steroid, the patient's WBC that had never gone in the 1 month after the treatment had never gone beyond 400, 500, they suddenly started jumping and they went to 2,500. We discharged the patient. The patient went home. So okay, he was on steroids. So we started the taper of steroids almost 3 weeks later. 3 हफ्ते के बाद जैसे ही उसका स्टेरॉइड को टेपर करना शुरू किया, पेशेंट के फीवर स्पाइक वापस स्टार्ट हो गए. सो दिस टाइम वी अगेन कॉल्ड बैक. रेवाड़ी से पेशेंट चला गया था, तो उसको वापस बुलाया, वापस एडमिट किया, वापस इवेल्युएट किया. Ferritin again that had come down to some 2,000 or something, again jumped to 30,000, 35,000 like that. So he had a relapse of the HLH that initially had been settled by a steroid and courses of IVIG. So जब second time हुआ, same thing, we jacked up the steroid. कुछ टाइम के लिए फीवर सेटल हुआ, TLC बढ़े. So practically this relapse of HLH happened 4 times. In the 4th time, he developed the Acinetobacter, bad bug infection, and ultimately he collapsed and died. So What I mean to say, HLH at times is a bad thing. There is good chance that steroids can rescue these patients, no doubt about it. But at the same time, when it is a relapsing remitting type of HLH, we had tried even anakinra for this patient. That's a relatively advanced drug for this indication. We had procured it from outside and given this medicine. But yes, ultimately at the end of the day, we failed in saving this patient. Fourth relapse of HLH, this patient could not be revoked and he died. Another case, 35-year-old female, Mrs. Gandhi. She is a professional in MNC. She presents with a gum bleeding and some low-grade fever for last 3 weeks. No organomegaly, otherwise low-grade fever and some bleeding manifestations for 3 weeks. A young female. This is the picture. Hemoglobin, WBC, platelets low, neutrophil lymphocyte preserved. Okay, so we worked entirely why the fever is not going. The fever is not settling. Serology negative, tropical workup negative. We did the bone marrow negative. PET scan did, PET scan was negative. Nothing was working out. So we have got a tool now that is available to us that is called BioFire. We send any patient who is like for whom the cultures are coming persistently negative, fever is still persistent. We are now more prompt to send the BioFire samples now. And supposedly we did the same for this patient. When we sent the BioFire for viral, something CMV came as positive. The cytomegalovirus came as positive. We sent the CMV viral load that was very high. That is usually less than 1,000. For this patient, it was more than 2 lakhs. She was treated with ganciclovir, followed by van-ganciclovir, and ultimately she recovered and she's still doing well. So although non-immunocompromised patients usually do not have CMV, but yes, we have seen before also, and this patient also proved that immunocompetent patients can also have CMV at times, even if the patient is seronegative, that is HIV negative. Another patient, 75-year-old Mrs. Irani. This is not Mrs. Smriti Irani, but yeah, she is Mrs. Irani. Presented with complaints of easy fatigability, bleeding gums, and joint pains, small joint pains, especially for the last 1.5 years. She had been worked up for the rheumatoid arthritis, but most of the times it had been negative, although she had a small spleen also. So technically, if the RA was positive, it was very easily, we could have called a Felty syndrome. But yes, the RA was negative, still a seronegative RA was still a differential. So she had received multiple units, approximately 1 unit in the last 2 months or so, and she had been receiving regularly blood transfusion for last almost 6 months or so. The patient said she has never taken any allopathic medicine so far on multiple rounds of questioning. So this was the evaluation: hemoglobin low, WBC low, platelets low, bilirubin was okay, borderline. So bone marrow was done. That was hypocellular, only 10 to 15% cellularity. Okay, what we need to understand here is the bone marrow cellularity for a patient who is 75 years age is expected to be around 25 to 30%. This patient has 10 to 15%. It is low, not very markedly low, but yes, it is low. So this patient was ultimately diagnosed to have an aplastic anemia. What is the point of contention here is, we most of the time saying, okay, rheumatoid arthritis, the patient would have been on methotrexate. That is the cause of pancytopenia. And we usually stop at that by giving GCSF. The problem is, the question that we want to highlight here is, even if it is a rheumatoid arthritis, we have seen before also, please do not start GCSF before doing a bone marrow. Please do a bone marrow test before starting GSF, because if it is a MDS, that can progress to AML by the medicines that we give. We don't want to do bad to the patient. So whenever in doubt, please do a bone marrow to confirm it is not leukemia. Pancytopenia should technically never be started on a GCSF unless and until you go ahead and do a bone marrow test to confirm we are not missing a leukemia. So that is the message that I wanted to give from this case. So this patient was ultimately treated with GCSF, Eltropovec, and things like that, and the patient had good partial response, and she has become now transplant independent. Another case, Mr. Modi, he is a 67-year-old male, a businessman who presents with low-grade fever and easy fatigability for the last 2 months. No significant physical examination. Pancytopenia is evident. Ferritin is low. Importantly, to highlight here, and what I wanted to highlight here is, so hemoglobin is low. There is a borderline pancytopenia. So hemoglobin low, platelets low, and a high creatinine. The first thing that we should not miss here as a medical emergency: low hemoglobin, low platelets, and high creatinine. So ferritin here is a confounding factor, I would say. In this presence, the first investigation that should be done is a peripheral smear examination. The peripheral smear in this case showed this. Any guesses? What is this? So in the interest of time, I think, these are schistocytes. These are all schistocytes that are present in the peripheral blood. And that means that fragmented red blood cells. So the TMA, the thrombotic microangiopathy, is a medical emergency. Maybe a couple of decades back, a patient who was diagnosed to have a thrombotic microangiopathy, we know, used to die. But now we are able to salvage more than 90% of these patients by the intervention of plasmapheresis. So plasma exchange is the treatment of any thrombotic microangiopathy. On the first suspicion of thrombotic microangiopathy, that is presence of fragmented RBCs, anemia, thrombocytopenia, kidney injury, in urgent plasma exchange should be started for these patients. Last case, 45 years old, Mr. Gadkari, who had complained of some abdominal discomfort and icterus, a relatively simpler case, icterus for 1 year. So he was a vegan, a non-alcoholic, just palpable spleen was there. He was reviewed by the gastroenterologist for the abdominal discomfort, but that he had been given some supportive treatment. But yes, these were his parameters: a pancytopenia, hemoglobin, WBC, platelets, preserved neutrophil lymphocyte ratio, bilirubin was slightly elevated, albumin was slightly low, spleen was marginally sort of enlarged, the bone marrow was reactive. So an ultrasound that was repeated at a different center had shown a coarse ecotexture, and that was suggestive of CLD. So again, what I mean to say is that this question I have raised before also, there are many times when the one ultrasound report shows a normal ecotexture for the liver, and we repeat it at another place maybe 2 or 3 times. Sometimes it comes out to be coarse ecotexture, sometimes it comes out to be a normal ecotexture. So that's a caveat that we face many times. And this is something that we need to streamline. I think not we, but the radiologists have to streamline that when they call a coarse ecotexture of a liver and when they call a sort of normal ecotexture of a liver, that is something that is not zeroed in, and the interpersonal variability in inter-observer variability plays a role in terms of delaying the diagnosis at many times. So that's the learning point for me, at least from this case. So yes, I am coming to the end of the talk, and these are some good things that we are trying to do. We are trying to enable all people who are suffering from any type of blood disorders by labeling them as Raktaveers. All these people are Raktaveers for us, blood warriors for us, and we try to support them in whatever way we can. We have been in news for some times, for like most of the time, good reasons. That's a quiz. It's a medical quiz. Any guesses that what is the diagnosis of this child? He is a 6-year-old boy who had been transfusion dependent for since 2 years of age. Every monthly he was requiring blood transfusion. This is the actual case. Low in height, weight was low for his age. What is the diagnosis and how do we treat it? I think in the interest of time, so that's another biphalangeal thumb, simian crease. So the answer is he was having Fanconi's anemia. So although this is the time of the photograph when I was doing my DM, at that time we had clicked this photo, and so yes, this child of course could not undergo a bone marrow transplant. He was managed with conservative androgens.
नमस्कार,
चल है
बढ़िया। आप कैसे हैं?
आपका केक तो वाकई बहुत मजेदार था
थैंक
So I think that's the last slide I have for the fun quiz. I'm going to end here. Any guesses for this movie name? The answer is
DDL दे दे प्यार दे
I think I'll stop here. I think I was well in time. I did not overshoot the time. If there are questions, we can discuss.
wonderful presentation, Dr. Meek. And now I would request all the participants to unmute themselves, and if they have any questions, they can ask Dr. Meek about that question.
Okay. Dr. Mustafil is asking.
Yeah.
So injection ganciclovir can cause pancytopenia. So how in that case you will manage or choose other drugs? So I think, hi Dr. Mustafil, how are you? So ganciclovir, I know we all know it's an antiviral drug that is a drug for CMV, and that is known notoriously to cause sort of pancytopenia inadvertently if it is continued beyond 1 week. So in this case, what we do usually is switch to either cidofovir, more commonly, or a foscarnet. So foscarnet is the safest antiviral drug that is available for CMV and HHV, herpes group of viruses, that does not have or very limited side effect of pancytopenia. So foscarnet is our go-to drug. Cidofovir is alternative, but yes, it is also known to cause nephrotoxicity and pancytopenia. So our go-to drug is either cidofovir or ganciclovir. That is one, and I think there is. Okay, I think there were answers that were coming. I didn't notice while I was giving the talk. I'm so sorry. Oh, Fanconi anemia was also answered by Dr. Zamat. Okay. So I think, yeah, I think the answers I couldn't sort of reply at the time when I was raising the question. I'm so sorry for that. But if there is any other question, we can discuss here.
Good evening, Dr. Meet. Dr. Pramila Malik here.
Hello, ma'am. How are you?
I'm fine. Excellent presentation. I just wanted to ask, once we get a peripheral CBC showing pancytopenia, then we refer to you, and then once you do a biopsy and aplastic anemia report is okay. So how do you proceed further to find out what all tests to determine that complement-induced destructive pancytopenia or autoimmune? What all tests do you do?
So, ma'am, what I understand is you are saying the bone marrow is aplastic. In
Bone
that
marrow
case,
is not aplastic.
okay,
Patient's CBC is showing pancytopenia, but
pancytopenia, yeah,
bone marrow, as such, you did a biopsy, it was okay. So
okay, normal marrow,
normal marrow.
okay.
So then how do you proceed to diagnose the reason of pancytopenia?
So, ma'am, in that case, I think,
It's that basically the reason must be destructive, na, as you said, that once it is coming out of this, either because of complement mediated or autoimmune mediated.
the differential that will come for a normocellular marrow. So again, a lot of things, madam, will come into pictures. For example, what is the age of the patient? What is the status of the organomegaly? If there is an organomegaly, most likely we are dealing with some type of lymphoma. That is a possibility. That is
Okay.
number one. Number two possibility, it can be MDS if it is an elderly patient, more than 60 years of age. MDS is a very common presentation, and that usually presents with a normocellular to a hypercellular marrow. Third possibility, it can be some viral infections, or maybe for that matter, any infections that can be
Mhm.
presenting with a normal cellular marrow and a pancytopenia. Fourth possibility, drugs is the most common. So most common wise, if I say drugs, infections are the first thing that need to be excluded before coming to a hematological cause.
But in drugs and this thing infections, will you get a normal bone marrow report? It will be
Um,
high.
so, ma'am, ma'am,
It will
again,
be
to say
hypocellular.
not necessarily, ma'am. Not necessarily.
Okay.
In fact, viral infections usually have a hapten-induced destruction, including for the drugs. So, hapten-induced immune destruction, as well
Okay.
as they can have a bone marrow suppression effect. So, either of these things can be seen. So,
Okay.
based only on the bone marrow normocellularity, we cannot exclude whether it is a drug or a viral-induced suppression. In
Okay.
fact, most of the times, more commonly, it is not the myelosuppression because of the infection. It is the hapten-induced immune-mediated pancytopenia that is more common than the
Okay.
myelosuppression leading to bone marrow hypocellularity. So
So
yes,
what besides tuberculosis and one case which you described, CMV related this thing pancytopenia, what all other infections are known to cause pancytopenia?
madam, CMV. So again, the most commoner viral infection starting from the
You said hepatitis A, one
common
case.
flu causing infection, that is the influenza viruses. Two,
Okay.
the HIV is a notorious thing to cause hepatitis. All viruses, the prominent feature being hepatitis A virus and hepatitis C virus. They are more prominently known to cause pancytopenia. CMV in itself is known, and as well as its treatment of CMV can cause pancytopenia. EBV is a very important cause that at many times the infectious mononucleosis at times presents with pancytopenia with tonsillar enlargement and fever. So that's the presentation of infectious mononucleosis. So that is another common presentation of a pancytopenia. But yes, in most of these cases, it will not be hypocellular marrow. It will be most of the times it will be a normocellular marrow with immune mediated pancytopenia.
Okay. Thank you. And one question I just wanted to ask, unrelated to pancytopenia. In
Yes.
pregnancy, what is the cause of poor absorption of iron? So many patients in non-pregnant state, thalassemia minor ruled out, their hemoglobin is very good. But during pregnancy, you keep changing the salts, but the HB keeps going down, and folic acid, B12, everything is being given. Iron studies show iron deficiency. So is it hepcidin related something during pregnancy that iron absorption is
What I
poor
was coming to,
during?
ma'am. So I would say the first possibility, if the if there is a documented iron deficiency in pregnancy, and if the hemoglobin is not rising and the iron levels are also not rising, the most likely explanation is inadequate dosing. So that is one possibility.
Dosing is okay, but the patient is passing. We asked the history. She's having black stools. It is just
No,
passing
that
out
is
in the.
okay. I mean, that is okay. Black stools can be because of the oral iron supplements also and because of bleeding also.
No, once the patient stops iron, black stools are not there. That is because of iron only. And
But
HB.
again, madam, what I mean to say that black stools is not a measure to suggest that the iron supplement is optimal. That is what I mean to say.
Okay. Okay.
So in that case, if the iron deficiency is persistent, that means the dosing of iron is inadequate. Please go ahead and give a IV iron. That's the best and
Maybe
safest.
that's what we are doing it. The
Yeah.
thing is ki, we are observing a lot of patients in pregnancy in which the iron deficiency is so common. Hello. Hello.
Ma'am, I think dosing is the issue. Ma'am, if the iron levels are remaining low, so again, if you are talking about the hepcidin pathway, in hepcidin pathway, the iron and ferritin levels will be high. So if you are saying after the supplement also, if the iron levels and the ferritin levels are remaining low, ma'am, it is inadequate
Yes.
dosing and nothing else.
No, dosing is okay. You even if you give 2 tablets, the absorption is not there. I had this thing. I read somewhere that hepcidin is produced, which causes the poor absorption from the gut during pregnancy.
So
There is
hepcidin path, yeah, please,
increased
ma'am.
production of hepcidin during pregnancy, which hinders the absorption of oral iron. So once we
So,
give IV iron, we have to give IV iron to so many patients in pregnancy, which is not required during non-pregnant state.
so I would say, ma'am, hepcidin is the latest molecule on the block that is associated with iron homeostasis. And most of the times, if your dosing is adequate and if the absorption is the effect, and you are saying that after giving IV iron, the iron levels are increasing, then yes,
Ah,
hepcidin is the likely culprit.
yes,
And
yes, that's what I'm saying. I think the hepcidin levels increase during pregnancy. That is the main
yeah,
reason for poor absorption.
I agree, ma'am. So hepcidin
Yeah.
is an iron it's a lock. So the role of
Yeah.
hepcidin in the body is wherever the iron is, it just locks it there.
So
In the
is it
reticular
increased
endothelial
during
system, it will lock the
pregnancy?
iron there.
Is it in, I'm just asking you, is the level of hepcidin increased during pregnancy?
This I'm not very sure, actually speaking. I'll have to go through this
हाँ,
data. I'm not very
because
sure about this.
बहुत ज्यादा मतलब पेशेंट्स में देना पड़ता है आईवी आयरन हमारे को ना.
Well, you are saying despite the optimal oral dose,
Yes, yes,
the
optimal,
patients are requiring.
optimal iron dose,
Ma'am,
changing the
again, the
salt
thing is,
from.
well, you are a gynecologist, ma'am, you will know better. But I think because of the increased requirement of the
No,
iron
the
requirement
dosing is
in the pregnancy, so
absolutely
despite that, you are
dosing.
saying they are not increasing.
Yes, yeah, dosing तो
That
पूरी
that's
दे.
a possible thing, ma'am. I'll have to
Yeah,
check that whether the
हाँ.
oxygen levels are
One,
increased in
I
pregnancy.
feel
I'll
that
have to
there
check
is
that.
some role of hepcidin during pregnancy. The levels are increased. That leads to poor absorption during pregnancy.
I'll check that, ma'am. I'll check that, ma'am.
Thank you.
Yeah.
Dr. Meet, excellent talk. Very nice. This is regarding PNH.
Ji, sir.
Sometimes, if you are lucky, you get that classic urine, which
Yeah.
is dark
Cola
colored.
colored, yeah.
Yes, yes. The technician will come running to you, sir. इसका तो बिल्कुल color ही different है. So
Sir, I'll share an interesting fact, sir.
uh,
The name is paroxysmal nocturnal hemoglobinuria. So
right.
it's an interesting thing. The prevalence of these three symptoms in PNH is 33% each. 33% of the times it is paroxysmal, 33% of the times it is nocturnal, and 30% of the times it is hemoglobinuria.
Right.
So yeah, that's an interesting thing about PNH.
Mm. Nice talk. Thank you.
So, if there are no more questions, then I would request our secretary.
Dr. Meet, can I ask a question?
Yeah,
Hi, Dr. Mustafil, how are you?
Yeah,
Thank
how
you
are
for
you?
joining.
Long time no see. You are looking so. Your presentation was excellent.
Thank you so much.
And
Thank you so much.
so, what you are doing nowadays with the PNH, especially is PNH, Pancytopenia patient? Are you doing bone marrow transplantation or what drugs you are using? And this type of case, my patient more the PNS clone more than 50%, more than 50, that is 60 to 70% in clear WBC and RBC. So how you will proceed to case of Pancytopenia?
So again, Dr. Mustafil, what I would say is the first line of treatment for these is definitely steroids. If the patient is not responding to steroids, you want to add some androgens, you can definitely do that. But most of the times, if the patients are having recurrent recurrent hemolytic episodes leading to drop in hemoglobin and requiring regular blood transfusions, or maybe the patient is having multiple thrombotic episodes, whether it is cerebral or some uncommon sites of thrombosis that are present, and these are the indications for proceeding to a bone marrow transplant. If it is a minor hemolysis, maybe you can just manage with the steroids and danazole and things like that are sufficient enough to take care of minor clones of PNH. But yes, if the clones are big and they are not responding to the conservative treatments of these oral medicines, a bone marrow transplant can be offered and should be offered. Again, eculizumab is a good treatment option, but the problem is how long to continue it. And at this cost, it is very difficult. It's available to us at relatively lesser cost than what it was before. We are getting one vial for 90,000 rupees now. So that's a very cheap cost of eculizumab that was available at one time to more than 2 lakhs for one vial. So now the cost has significantly come down. But despite that, how long to give it? We don't have an answer. Bone marrow transplant is a much cost-effective treatment option for these patients, actually.
So what is the success rate of bone marrow transplantation in this case? And if I can start the steroid, it is very long time, young patient, 22 to 25 years old, he wants to marry, and danazole and steroid long time, osteopenia, so many problems, the impairment, very difficult. So what is the oral drug versus bone marrow transplantation? What is your experience? Have you done a bone marrow transplantation in this case of PNH?
So
And what is your experience?
Again, two things. One is, what is the cutoff? Maybe if you're asking, what is the cutoff dose of steroids beyond which we should counsel for bone marrow transplant? So a patient is there. We have seen patients multiple times. Okay, once in a while, once in 6 months, the patient requires a short course of steroids for 2 weeks, 3 weeks. Hemolytic episode subsides, and then he's back to normal. So these type of kids or children or maybe adults should not be offered a bone marrow transplant, according to me. If they are steroid dependent, and the definition of steroid dependence is more than 28 days of steroids, the patient is continuously requiring more than 15 milligram dose of steroids for more than a month or so, that is considered as steroid dependence. And these patients should be offered a bone marrow transplant to avoid the side effects of steroids. Regarding the experience of bone marrow transplant, the success rate is really good. 70 to 80% for a full match donor is a good, it's just like they behave like a thalassemic kid. Adult patient with a thalassemic kid, they behave, BUSI is the conventional conditioning protocol, and the outcomes are really good. The only odd thing that here we have to mention is, even after a bone marrow transplant, the only risk that is not mitigated related to PNH is the thrombotic risk. So post-transplant also, for a patient with PNH, the thrombotic risk persists, and that is the reason why they should be given long-time anticoagulation, maybe at times requiring for life also. That is the only risk that is not mitigated by a bone marrow transplant in PNH.
Thank you very much.
Okay, nice talking to you, Dr. Mustafa.
Thank you very much.
Yeah.